Thank you for joining iMeet. This meeting is now being recorded.
Good evening. This is Russell Miller from the Naval Medical Center in San Diego, and along with my co-moderators, Dr. David Shaw from UCLA Heart Review and Ara Christensen from Loma Linda, we are extremely excited to have you here tonight for the August 2017 AABIP webinar focused on the role of cryobiopsy in interstitial lung disease. Before we start, we'll go through some quick housekeeping issues. Next slide. This webinar will be recorded for future viewing by members on the AABIP website. Please mute your phones to minimize any background noise, and feel free to adjust the volume in the bottom left-hand corner. During the session, you can use the chat box to ask any questions of our guests, and we'll accumulate those questions as time goes on for appropriate time points. The projector screen icon on the bottom left toggles slides and videos. AABIP does not specifically endorse any technologies or products, and the contents of this presentation represent the opinions of the speakers. Our guests today are Dr. Ryan Kerr from Mayo Clinic, Rochester, and Dr. Fabien Maldonado from Vanderbilt University. They will both be discussing their aspects of lung cryobiopsy for interstitial lung disease. So without further ado, I'd like to turn over to Dr. Maldonado.
Well, thank you very much for the kind introduction. So what we were thinking about doing for the next hour or so is to give you a kind of a general overview of a topic that I think has generated a lot of interest, which is that of cryobiopsies for interstitial lung diseases. What I'd like to do is go over some of the reasons for thinking about doing these things in the first place. If at any point in time you have questions, don't hesitate to use the chat box at the bottom of the screen. I may or may not answer right away, but we'll address your question in due time. And then if you can't hear me for whatever reason, please let me know as well. Okay, so the first 20 minutes or so will be presented by myself, and we'll talk about some of the rationale to think about doing cryobiopsies for ILD in the first place. And then Ryan will talk about the interesting stuff from a technical standpoint, at least, on how best to do this as far as we believe it is safe to do it, and go over some tips and some guidance, procedural related guidance at least. So the title of the talk is a step forward in disease management. For those of us who have been in the ILD field for some time, this is directly referring to a letter to the editor, to CHEST, after Anna Louise Kazenstein had published a paper on the utility of transbronchial forceps biopsies for UIP, which was quite controversial, and we'll go over some of these data. But clearly there's a lot of interest in cryobiopsies as a potential alternative to the current paradigm of surgical lung biopsies. All right, let's see if I can move these slides here. I'm not seeing my slides moving. Okay.
I can advance them for you.
Yeah, perfect. Very good. Okay, good. Thank you. All right. So here's the outline of the talk, or more precisely, the contentions I'm going to try to defend, highlighting the importance of an alternative to surgical lung biopsy for ILD. So first of all, I think it's important to understand that the current classification of interstitial lung diseases is still primarily based on histology. And then I'd like to make the point that an accurate diagnosis of ILD is actually critically important, and not something that everybody feels comfortable accepting or stating. Surgical lung biopsies, whether it's justified or not, are largely underutilized, and there's some data that I will show you in that regard. And clearly, conventional transbronchial forceps biopsies are insufficient in the vast majority of cases for the diagnosis of ILD, and I'll explain to you why that is the case. And finally, I'll briefly go over some of the data on cryobiopsies. There's clearly increasingly published and peer-reviewed data on cryobiopsies. We'll go over some of these, although not in a comprehensive fashion. Next slide, please. Okay, so by way of introduction, I'm sure you're all familiar with what ILD is. I think as interventional pulmonologists, we've moved away from that field, and the emergence of cryobiopsy is a good opportunity for us to re-engage that part of pulmonary medicine. But as you know, it's a broad and heterogeneous group of diseases that share the common factor to interest the interstitium to a certain extent. It is estimated to affect 1 in 3 to 1 in 4,000 people in the general population. There's tons of very heterogeneous diseases, but of course IPF, connective tissue disease-related ILD, and sarcoidosis account for most of these ILDs, about 75%. Now, IPF has traditionally been regarded as a fairly rare disease. In fact, it represents 30% of all ILDs, and although there's a little bit of debate on incidence and prevalence, the lower estimates of mortality for IPF in particular is 15,000 deaths every year in the U.S. That's the same as ovarian cancer or esophageal carcinoma, with upper estimates around 40,000, which makes it, as big a killer as breast cancer. 30,000 in Europe. So clearly, this is not a rare problem and something that we're picking up more and more, primarily because we're doing a lot more CTs than we used to. Next slide, please. All right, so whenever we send a patient to the ILD expert, this is a little bit the feeling, I think, for some of us, that they go through a lot of useless mental exercises and a lot of pontificating and come up with an alphabet soup of a diagnosis that may or may not be relevant to patients. And the nihilistic attitude, I guess, is, well, you've got some kind of inflammatory lung disease or fibrotic lung disease. Let's put the patient on steroids and see how he does. And I'd like to make the point that this is the wrong attitude for a number of reasons. There's clearly a role for making an accurate diagnosis of ILD. Next slide, please. Okay, so understanding that these very confusing nomenclature is fairly old. It was first characterized by Avery Libaugh, who's a famous pathologist from Yale, who spent most of his career at UCSD, actually. He, in the late 60s, decided it was time to classify these fibrotic lung diseases, which represented the third most common cause of respiratory mortality. And it had not been quite looked at. And so he started looking at all these different slides from pulmonary fibrosis and realized that they fell into a number of different baskets. And the most common type was actually the usual type, usual interstitial pneumonia, which, as you know, is the sine qua non condition to make the diagnosis of IPF. But there's a number of terms here that you see have been trickling down through multiple classifications to end up in our current classification. The problem with this classification, of course, is that there's no direct correlate between what the underlying lung architecture looks like and what the patient is experiencing. In other words, there's no great pathological clinical correlation. We need more information to inform a diagnosis and management. Next slide, please. And so what's emerged in the late 90s and early 2000 is this idea of multidisciplinary discussion. The idea here is that indeed the pathologist is seeing only part of the problem, but need input from radiology and from the clinician to get a better comprehensive picture of what's actually going on with the patient. And from collaboration between all these different specialties emerges a clinical diagnosis that seems to make sense for the patient and inform clinical decisions, but also a diagnosis that everybody seems to be agreeing on. And so we've moved from the gold standard of histology to the so-called silver standard of multidisciplinary discussion. And this, I think, has translated in the general popular opinion that perhaps histology is not all that important anymore. Next slide, please. The seminal paper that really enshrined this idea of multidisciplinary discussion is this seminal paper by Kevin Flaherty, and what he looked at here is the value of sequential introduction of different levels of information to the confidence in the diagnosis between clinician, radiologist, and pathologist, but also in the degree of inter-observer agreement. In other words, you have a number of people looking at things on their own, and then they start getting radiology reports, and they start getting histology reports, and then they discuss these reports together, and they seem to come up with a good agreement on what the disease might be. Now, what's really interesting, next slide, please, is that when you look at the respective contributions of all these different pieces of information, the big bump in inter-observer agreement as captured by the kappa value here is really at step 4 and 5, which is essentially when you add the surgical lung biopsy results to the discussion. In other words, next slide, please. In spite of this multidisciplinary discussion, the histopathologic information still has the greatest impact on the final diagnosis. So the idea that having this multidisciplinary discussion somewhat or somehow obviates the need for histology is not accurate. Next slide, please. Now, we're talking about surgical lung biopsies as opposed to forceps lung biopsies or bronchoscopic biopsies for the primary reason that the disease to exclude or rule in is UIP, and which is obviously the histologic substrate of IPF. And the reason why we need a surgical lung biopsy is that we need large biopsies that will allow us to see these alternating areas of normal lung and areas of destroyed architecture. Let's see, I don't think I can show you. My pointer doesn't work, but you see some nice, here we go, alveolar tissue here and a lot of architectural destruction. At higher magnification, you can see these fibroblastic foci and then this extracellular matrix deposition. And you really need to see these alternating areas of normal and frankly abnormal lung to call the diagnosis of UIP, hence the need for large tissue biopsies that have little crush artifacts, both of which we cannot achieve currently with forceps biopsies. Next slide, please. So the problem, of course, is that we've seen a decline in surgical lung biopsies, specifically for IPF, as shown on this graph here, since about the 2000s. But the surgical lung biopsies for ILDs in general have remained relatively flat. And this is a great paper from Hutchinson that was published last year. And this is looking at the largest inpatient database we have in the United States. So this represents 7 million inpatient stays. And as I mentioned earlier, ILDs have increased in incidence over the past 10 to 20 years, and so the fact that the surgical lung biopsies are remaining fairly constant is actually a suggestion that we're not doing as much as we used to. But clearly, with regards to suspected IPF, we're doing a lot less, and this seems to have happened in the early 2000s for a variety of reasons, I think, that I listed below here. First, the recognition that high-risk CT in a number of cases will help you make the diagnosis of UIP without tissue diagnosis, but also the problem of safety of surgical lung biopsy and this attitude that if we don't really have a good treatment for IPF, why bother making the diagnosis anyway? I keep pushing the next slide. It's not working. I don't know if let's see here. Next slide, please. Oh, it's working now. Great, wonderful. Okay, good. So let me go back to the previous slide here. So the idea that high-res CT has essentially replaced histologic diagnosis is incorrect for a number of reasons, but primarily because the typical UIP pattern on high-res CTs, by all estimates, happens in about 50% of all IPF patients. So we're going to miss a substantial number of patients with IPF if we do it that way. The current status quo is that if you look at the ASCEND trial and the IMPULSIS trials, which were respectively the pirfenidone and nintedanib trials, you still have about 20-30% of patients that underwent surgical lung biopsies, highlighting the importance of surgical lung biopsy. But even before we got these effective drugs for IPF, I think there was clearly a point for making the diagnosis of UIP. First of all, you want the patient to know what he's supposed to expect with his disease. We know that UIP confers a really poor prognosis, but also importantly, if you restrict yourself to making the diagnosis of UIP on the basis of a high-res CT, your patients are not going to do quite as well as if you biopsy them, not because we're doing good things with biopsies. We're actually harming patients with biopsies. That's the point of the talk. But you're capturing a selection of patients earlier that may potentially benefit more from antifibrotic agents like pirfenidone and potentially be eligible for transplants, which may not be the case later on in the disease. So important to consider a biopsy. The main reason why surgical lung biopsies fell out almost completely out of favor for IPF is because of this particular paper that was published from Mayo in 2001 by Jim Utes. And what they did in this paper is essentially look at 10 years' worth of surgical lung biopsies, and they looked specifically at patients who ultimately had a diagnosis of UIP. And they identified 60 patients, and they found out that 10 of these 60 patients died within 30 days, which is, if you calculate it, number needed to kill of 6. So it's pretty bad. You got to make a good case for your patients to accept this. Now, arguably, a lot of these were thoracotomies, and a lot of these patients were acutely declining at the time of the biopsy, which is now considered a contraindication, at least relative contraindication to surgical lung biopsy. So you would think, well, maybe we've gotten better over time and surgical lung biopsies are safer. Well, that's not the case. And can you guys see my slides here? We're on the back on the Hutchinson paper. I'm going to take that as a yes.
Let me advance for you. I'm not sure if everyone's caught up to you.
Okay, very good. All right, you can advance a couple more slides here. So let's stay here. I don't know if you heard me when I said this, but this was a very important paper that really drove the practice of surgical lung biopsies for IPF, essentially demonstrating a very high short-term mortality in patients ultimately diagnosed with UIP after surgical lung biopsy within 30 days. This was a 16% mortality within 30 days. Next slide, please. And so, as I was mentioning, the question is, well, are we doing better? So looking at the next decade from 2000 to 2010, 2011, again from the Hutchinson paper published last year, you can see that the mortality remains quite high, not quite 16% as the Jim Utes paper that I just mentioned, but still 1.7%. That's one patient in 60 that will potentially die from surgical lung biopsy. So that's a very high mortality rate, I think, for an elective diagnostic procedure. Now, importantly, when you look at so-called, quote, non-elective patients, those patients that presumably were having an acute deterioration before the procedure, this patient have still a 16% mortality rate. This is obviously something that is not acceptable and calls for an alternative to surgical lung biopsies. Now, at a meeting that I was at with Tom Colby pointed out to me that this actually represents more than 10,000 deaths from surgical lung biopsy during that study period, which seems amazing, but is in fact true. And so clearly we need to come up with better solutions if indeed histology remains a critical part of the diagnosis. Now, you've seen these papers before. This is a paper from Anna-Louise Katzenstein that led to the famous letter to the editor that transbronchial biopsies represent a step backwards in the diagnosis of IPF. What we know is that if we know that patients have UIP histologically and we look back at transbronchial biopsies, we can pick it up in about 30% of the time, which obviously is not really what happens in real life. I don't know of any pathologists that will confidently call UIP on the basis of forceps lung biopsies. Now, there's a lot of diagnostic yields for forceps biopsies within the realm of ILD. The problem with that is that the endpoints are often not clearly defined. And so if we look at this paper from Michigan that was published probably just 6 months ago or so, their rate or their diagnostic yield for ILD with transbronchial forceps biopsy is about 20%, which I think is probably a good number. So clearly, transbronchial biopsies, forceps biopsies, are not a good solution, and we need an alternative. So the ideal alternative, I think, for interstitial lung diseases would be a minimally invasive procedures, if possible, using flexible bronchoscopy, as rigid bronchoscopy is clearly not quite as popular as it used to be. But we need larger biopsy specimens than those that we can acquire currently with forceps biopsies. And we'll also need to be able to obtain, hopefully, biopsies from different lobes. We know that there's a significant number of patients that have UIP pattern in one lobe and NSIP in another, a lot of interlobar heterogeneity. I should be on slide 20 at this time. So, and sorry for the technical problems. Hopefully the slides will be made available to you at some point. Importantly, we'd like to have a minimal crush artifact whenever we use forceps biopsies, whether they're rigid or flexible forceps. We're going to get a significant amount of crush artifact, which is actually more of a problem for the diagnosis of ILD than it is for malignancy, primarily because we need to see the architecture of the lung, which is not necessarily the case for malignancy. And of course, we'd like to have a safety profile that is similar to that of conventional bronchoscopy. I think here we're going to be a little bit careful. There's been a lot of debate recently in the literature about cryobiopsies and how dangerous they are. We need to remember we're comparing ourselves to surgical lung biopsies and not to conventional bronchoscopic forceps biopsies. That would be an unfair comparison to compare our yield to surgical lung biopsy and yet to compare our complication rate to forceps biopsies. But hopefully we can have at least a better safety profile than that of surgical lung biopsies. Next slide, please. I'm going to stop advancing my own slides because it doesn't seem to be working. Okay, so that's where cryobiopsies come in. And as you know, cryobiopsies have been around for some time. They are essentially probes that were developed to generate very negative pressure at the tip. And the way this works is, as you know, some compressed gas, which can be nitrous oxide, but more commonly CO2, that expands rapidly at the tip here, resulting in a profound decrease in temperature, about minus 89 degrees Celsius for the nitrous oxide and minus 79 for the CO2, which I think most of us would be using, so not quite as cold. And then the gas is vented in the atmosphere. I point that paper. This is the first report of a cryoprobe, and initially these were used for neurosurgical procedures, essentially to get an idea of the reversible effect of what it would be to remove a portion of the brain before it becomes irreversible, which is kind of interesting. Next slide, please. Yep. Perfect. So we obviously have now flexible cryoprobes. We've had this for a long time. The only reason to use cryoprobes until we started doing cryobiopsies, or the most common reason, was to remove clots from the airway. But these were primarily designed for tumor destruction in the central airway, and the initial use was a fairly cumbersome way to do it with a lot of freeze-thaw cycles. Until people get impatient and started just freezing the tumor and just plucking it out of the central airway. And that gave the idea to Martin and Jürgen Hetzel, the two German brothers, to maybe do this in the peripheral lung and see what they could get. And so they published their first paper in 2009, I think, and showed the feasibility of peripheral cryobiopsies for a variety of lung diseases, but essentially showed that it was, as far as they could tell, relatively safe and could procure fairly large biopsy specimens, and more importantly, devoid of crush artifacts. So that was became all of a sudden a very promising use of the cryoprobe. Next slide, please. And here are the number of publications that have been coming out for cryobiopsy, specifically in ILD. And as you can see, since that original paper back in 2009, a couple slides back, a little bit more. Perfect. We've had almost this exponential rise in publications. Still not a ton of literature on the topic, but clearly seems to be exploding every year. I checked yesterday, and we have about 50 publications for the year 2017, specifically addressing cryobiopsies in ILD. So something that at least is generating a lot of interest. I think there's more people publishing meta-analyses these days than actual original reports, but at least in the U.S. But that's okay. At least people are talking about it, which is important. Next slide, please. This is one of these meta-analyses which was published by the Italian group from Forlì, so the Poletti group, and this is a little bit old now. There's a lot more studies specifically addressing ILD, but the yield is about 80%. Again, we have to be careful. The diagnostic yield is reported very differently across studies, and so we have to be mindful that the yield may not be quite as promising as it looks here. Next slide, please. In terms of size, this is from our paper we just published in the last issue of JOB, and this is a distribution of cryobiopsies across 104 procedures, so hundreds of cryobiopsies, and they all pretty much cluster around 5 millimeter in larger diameter, which is incidentally something that a pathologist, Tom Colby in particular, think is the right size for a biopsy for ILD. Now there's giant biopsies that I don't have a picture of the 3 centimeter cryobiopsy, but I got one of the 2 centimeter. Next slide, please. And here it is. It's pretty impressive, I think, and this was obtained in a patient without much complication. But you can see that we're now talking about biopsy sizes that start to approach what you could get with a wedge resection. Next slide, please. So in terms of the ultimate ideal size of the biopsy, it's not very clear, but according to Tom Colby from Mayo Scottsdale, 5 millimeters is really what you would need to call the diagnosis of UIP, at least based on a cryobiopsy. And here are, for example, some circles that he drew on this wedge resection of 5 millimeter cryobiopsies or sizes that would correspond to a 5 millimeter cryobiopsy. And you can see that you can see these alternating areas of normal lung and fibrotic lung. Next slide, please. The best data we have suggesting that indeed cryobiopsies offer a substantial piece of information and contribute significantly to the diagnosis of ILD is this paper that was also from the Poletti group in Italy. And what they did is actually pretty brilliant. They essentially took the Flaherty protocol that I mentioned earlier and tried to figure out what the respective contributions of cryobiopsies on one hand and surgical lung biopsy on the other was to the confidence in the diagnosis. And as you can see on this table, as you introduce data from the surgical lung biopsy and the cryobiopsy, you go from about 30% high confidence in the diagnosis to 60, and then ultimately 80%. And there really wasn't any difference between surgical lung biopsy and transbronchial cryobiopsies, and the two groups there were fairly homogeneous. In fact, the kappa value for inter-observer agreement was in fact better for cryobiopsy than it was for surgical lung biopsies. And all these biopsies were reviewed. This was a retrospective study, but nonetheless really well protocolized. It's something you want to probably take a look at if you're going to try to make the case for cryobiopsy at your institution. Next slide, please. I'm going to pass quickly here. Just show you that in these two slides, this is a paper that one of our colleagues here at Vanderbilt just published, and it's probably the best summary of the evidence out there. But the 2 points of these very busy slides is that there's a lot of variability with regards to complications, which is probably due to the fact that we're all reporting our complication rates differently. Specifically, the bleeding rate, serious bleeding may be very different for Ryan than it is for me, or vice versa. And also, it's going to have a very different significance for somebody who's going to be using a prophylactic bronchial blocker, which only needs to be inflated to stop the bleeding, versus somebody who's going to be doing these procedures without any precautions, which is not advised. The other slide is that there's, of course, a lot of variability in the way we do things. And that clearly calls for some standardization of the procedure. Now, of course, we don't have tons of data to guide us, but we've tried to come up with some general guidelines that are currently in the second round of revisions that should come out fairly soon. This is primarily a European-based document that will come out, but we also have a document that we're starting to work on with the ACCP and that the ACCP has agreed to sponsor, and this will be a consensus statement on cryobiopsies in ILD. Next slide, please. And this is just a group of people that is working on this. You can see all the names here. There's a cryobiopsy meeting in Europe. There's the fourth iteration of this meeting in upcoming October. And in fact, it was at that meeting last year that a number of us raised some concerns about the widespread adoption of the technique with a lot of variability in the technique. And so we decided we would at least try to get together and come up with some general recommendations. Next slide, please. And this is my last slide here. Again, this paper should come out fairly soon, but these are the general guidelines. I'm just going to read them because I think Ryan is going to take over at this point and go over the technique and highlight a lot of these points. But just like in the case of surgical lung biopsies, a patient that's acutely declining, and when I say acutely, this is within the past month, this patient probably should not be biopsied until it stabilizes. You're unlikely to change the diagnosis. You're actually likely to cause trouble with acute exacerbations and so on. Pulmonary hypertension, we don't have any data to suggest that this is a problem, but we're going to recommend that RVSP more than 50 millimeters of mercury should be considered relative contraindication. We should, of course, be cautious about being able to handle a bleed when it occurs. The PFT values below which we think cryobiopsy should be at least relatively contraindicated would be FVC of less than 50% and diffusing capacity less than 35%. We have no data on age. We've done cryobiopsies in relatively old patients, more than 80 years old for sure, and in Europe they've done children as well. Probably not advised. You probably want to start with a more quote conventional patient end quote, but we were not able to come to an agreement with regards to age. What everybody seems to be agreeing on is that the patient who should at least have a very deep sedation, if not general anesthesia. You don't want the patient jumping up the table. There needs to be an airway, an endotracheal tube, or a rigid bronchoscope, and a bronchial blocker that you will be able to inflate as soon as you get a bleed, or even potentially prophylactically, and Ryan will go over this. Now, if you're going to do this, you need to give yourself a chance to actually make the diagnosis. That means you need to at least get 3 to 5 biopsies. 5 would be a good number. 1 centimeter from the pleura, because this is where you're going to get your secondary lobule, and this is going to be more helpful from a diagnostic standpoint. Increases the chance of pneumothorax, but at that level, the risk of bleeding is less, and so it's kind of a trade-off between bleeding and pneumothorax. And I can tell you that pneumothorax is probably something you want to deal with rather than a bleed from cryobiopsies, which are often problematic. You need to use fluoroscopy to at least get a sense of how close to the pleura you are. And then, of course, you should have immediate equipment, expertise available. Most of us are interventional pulmonologists and well-versed in dealing with complications from bronchoscopy. An important point that we started to work on is developing a registry. I think we won't have any real-life data on cryobiopsies until we get a registry going with systematic documentation or recording of complications and yield and so on. Okay, I'm going to stop here and then leave it to Ryan, and hopefully we'll get to answer some questions at the end.
Great, thanks, Fabien. Okay, I hope everyone can hear me okay. I'm just going to talk a bit here about some technical considerations of the cryobiopsy. Fabien just touched on some of these things, but oh boy, this is really skipping around. Sorry about that. So first off, I just want to say that there is no universally agreed upon technique for transbronchial cryobiopsy, as Fabien pointed out. But I do want to point out the way we do it here at Mayo, and which is actually the same way that Fabien does it at Vanderbilt, and maybe defend a little bit the reasons why we do things the way they do it. So I want to talk about informed consent, procedure location, sedation and airway, prophylactic management of bleeding. He talked about endobronchial block. I'll talk a little bit about more how we actually use that and show a video of that. then go over the cryobiopsy tissue acquisition itself, and then talk about the management of acute and late complications. So first of all, I just have a little poll for the audience. I hope everyone can see everything okay. So just a poll for everyone. What do you tell your patients the risk of pneumothorax is? Just wanted to get a general feel for the audience when you're consenting your patients. Is it 1%, 5%, 10, 20, or 30? And so, David, it keeps jumping forward. Is that happening? Something we're hitting here?
Yeah, it's happening on my end as well. If you want, let me try to reload this, and but I'm not sure if that's going to correct the problem. But
okay.
we'll do what we can.
I'll just have you do. I'll just have you.
While we're doing that, it looks like the vast majority of answers are between C and D.
Okay. And we're just going to reload this. So great. So I expected that we'd get quite a few answers, and that's not at all surprising based on the various studies that Fabien showed you, that based on the types of technique and ways people do that, the data is quite all over the map. I wanted to ask one more question here as well. What do you tell your patients, if you talk to them at all about it, what the risk of moderate to severe bleeding is?
So the answers so far seem to be
kind of in the B to D range, it looks like.
Yeah.
And next slide, please.
You want me to sit with you?
And so, that's great, and I expected there to be answers all over the place. But, the most recent systematic review that just came out was pretty nice in that it just looked at published studies, and they defined in this study incidence of grade 2 moderate to severe bleeding as about 5%. But it really has to do with how you define this, and so I think this is going to be all over the map. But if you are starting a cryobiopsy program, I can tell you that's probably going to be very much the lower limit of what you're going to see, and I think that would be a starting number to consent patients. In this meta-analysis, the pneumothorax rate was about 10%. So I think those are at least useful numbers to have in your mind if you're just trying to give a patient a general sense. Next slide, please. So the cryobiopsy working group mentioned immediate equipment and expertise available, and Fabien already touched on all of these, so I won't go over all of them, but I think it's really important, particularly for a bronchoscopy suite that maybe doesn't do a lot of chest tubes, to have chest tube supplies available, either pigtail or surgical chest tube. And then I think just as importantly, you want to have personnel who are really familiar with this. If you have a pneumothorax, you really want to be able to ask for all the things that you need right away and have technicians know what that is, and something we even run into if we have to do procedures off hours. So it's always important to have, I think, your core team together when you're doing something like this. Next slide, please. And so the next thing, sedation, airway, and bronchial blocker. So the cryobiopsy working group suggested general anesthesia, deep sedation with an ET tube and a blocker. But I wanted to readily acknowledge that there's a lot of variations in the literature, and there are people who don't do this, and I think they can probably defend themselves. One study looked at 56 patients, just published in 2016, using moderate sedation with fentanyl, midazolam, using a 2.4 millimeter probe. No tube, no blocker. They had a 20% pneumothorax rate, and one person needed balloon occlusion, but importantly, they didn't report any major complications. Next slide, please. Another couple studies had some similarities. A recent one was published with 106 patients, again using moderate sedation with the smaller cryo probe. They used a nasal oxygen catheter above the larynx, and they had a novel two-flexible scope method where the first biopsy was taken and the biopsy was pulled out, and then another scope was quickly advanced in to monitor any bleeding or do any wedging or do whatever else needed to be done. And quite impressive procedure time of only 9.7 minutes. They said they had very low complications rate with about a 5% pneumo rate and no major bleeding. And a similar 74 patients that were looked at, again, with a two-scope technique that they thought worked pretty well. So I'm just highlighting these techniques to acknowledge the fact that there are other reported techniques out there. Next slide, please. But I think probably others have picked this up as well. When you go to some of these national meetings and you talk to people about their first few cryobiopsies, I've heard a lot of really scary stories about some horrendous bleeding. And one study that has shed some some light on some of these stories that we had only just talked about was a really nice paper, I thought, describing a high complication rate after introduction of cryobiopsies at a big academic center here in the U.S. And they looked at their first 25 cases of cryobiopsy using a variety of sizes of probes with a 2 to 4 second freeze. They did use an LMA in 21 out of 25 patients. They didn't have any broncho blocker or any occlusion balloon. And importantly, they had a back, please. They had 5 out of 15 without fluoro had a major bleed, and in fact, they had an episode of a near catastrophic bleeding with life-threatening shock and prolonged critical hypoxemia. And I think this really comes down to, when we're doing preventative measures in medicine, how many unnecessary procedures do we need to do to prevent one critical event like this is described. And so, next slide, please. And so that's leads me to the method that we have taken here at Mayo. We like everyone to be under deep sedation. Back, please. And the most important thing for us is that they are comfortable. Like Fabien said, we don't want them jumping off the table. We really want their diaphragm to not be having huge sways so that we can accurately position the cryoprobe and get a good freeze, since it is a contact freeze. We do typically use a size 8 endotracheal tube with the blocker external to the tube, and I'll show you that. We use a 1.9 millimeter probe. We do use fluoroscopy, typically pull back a centimeter, maybe a little bit more than that, with a 4 to 7 second freeze, taking 3 to 5 biopsies in the lower and or upper lobes, and usually 1 per segment. Next slide, please. And we've found that the type of endotracheal tube makes a big difference if you're going to be fiber optically intubating them with the blocker external to the tube. And so we've used a very soft silicone tube, and the advantage here is it has, let's see, can you see my pointer? Okay. It has a very beaked bill. It's extremely soft, squishy silicone, and that really allows it to slide right through the vocal cords without having to spin it or twist it, which allows for very atraumatic intubation. In fact, patients can be fairly awake when we get this tube through. Next slide, please. And the blocker that we use just happens to be this ARNT 9 French endobronchial blocker, and we occasionally use the 7 French depending on where we're doing our biopsy. But there are other blockers out there that will work just fine, but this one is pretty versatile. It's not too expensive, and we found it to be adequate for our needs. It will come in a package just like this, and all we use here is the blocker and the syringe to inflate it with air. We don't use these other parts that might be used with anesthesia for single lung ventilation. Next slide, please. And so we take out the balloon, and it's a good idea to always test the balloon. And so the syringe hooks up to this part here. This is where the string is attached at the end there, and that's the loop that hooks to the scope. And so we test the inflation just to make sure everything is working. Next slide, please. Then the loop is attached to the tip of the bronchoscope that's already been loaded through your endotracheal tube, and you can see that cinched up here. Now, if you just leave it like that, that's going to come uncinched, and the whole thing's going to fall off. And so next slide, please. We do have usually use a clamp or have someone hang on to this so that the blocker doesn't fall off when you're placing the blocker. Next slide, please. And placement of the blocker is quite easy. The patient is relatively awake and cooperative at this point, or at least not apneic is really the key. And you advance the bronchoscope into the airway. You park the tip of the scope in either the right or the left mainstem bronchus. You release that little clamp, and you deploy the blocker. Now, one critical thing you want to do is someone needs to hold on to the blocker as the ET tube is advanced over the scope so that you don't inadvertently push the blocker down deep. These are pretty stiff, and that could cause some real damage if that were to happen. Next slide, please. This is just a view from the larynx side. So you can see the arytenoids here, and here's the blocker coming in external to the ET tube. Next slide, please. Then we inspect our cryoprobe. We give it a good freeze. We want to make sure that we get a nice ice ball that forms pretty quickly, as I think most of you know. Next slide, please. A couple pitfalls here. If your cryoprobe isn't working really well, you can get a really bad biopsy. And I think a poor freeze is probably, in my experience, seems to cause more harm than a good freeze, because you don't get the hemostatic effect, and you take an unnecessary a biopsy and you don't get much. So you really want to make sure you get that good ice ball. And if you're not getting that, You really want to look carefully for any kinks in the cryoprobe. These can get bent during sterile processing. If you look closely here, there's actually just a small hollow wire channel that runs through it. It's actually quite fragile, and so you really want to make sure that that's not an issue. And I have a question here: Do we standardize ice ball size? You know, it becomes a little bit of an eyeball test. If you do this enough, you kind of know what a good ice ball looks like. And if you go back in fact, I'll go back a slide here. That's about what it looks like, but I don't take out a measurement or anything like that. So another question was proposed: how do you get the blocker through the cords outside the ET tube and bronchoscope? Let me just back up one more slide here, a couple more slides. So the blocker is secured to the tip of the bronchoscope, but it is external to the tube. And so this part gets down into the distal trachea, and you release the tip of the blocker, and now you've got the blocker in the airway, and then the tube slides in right next to that. Does that make sense, Russ?
Yeah, that makes sense. I was just, so you'll actually load it and intubate with the blocker attached to the bronchoscope and then advance your ETT tube over.
Exactly. Yeah, you keep the patient fairly spontaneously breathing. You don't want to get him apneic at this point. So you want to get the scope down, drop the blocker, and then this ET tube slides very nicely. And one important point: if you have a stiffer tube that you have to maybe spin to get through the cords, that can really be a lot more difficult with the blocker. So the type of ET tube you use, we found, really does change things dramatically for how easy it is to get the blocker positioned. And so that's what things will look like. You'll see the blocker external to the tube and park there. Tank pressure, we found this to be pretty critical as well. When it gets to the low green, you just don't get a very fast freeze. It might be enough to do an endobronchial tumor debulking or something like that when you just need it to be sticky. But when you want a real good flash freeze, you really want a nice and full tank. And so we had a tank once that was only filled to about here, and it just wouldn't give us a good freeze, and immediately got better when we had a full tank. So just something to watch for. So now we're going to show a video. David, if you want to show video 1. And so here's the blocker that was deployed. And here's that little loop. Now, sometimes that can get in the way and you can pull it back, but it's also really handy in case you're in the wrong airway. You can pop it to the right or the left by grasping that. And so you don't, of course, need a wedge because you're going to be pulling this out anyway, but you do want to position it so that you can see what airway it goes into. And now the cryoprobe is advanced out. You can see this patient is nice and calm. You don't see much diaphragm movement. The cryoprobe was pulled back a little bit more than a centimeter there. In this case, there's probably a 5 or a 6 second freeze. The probe is pulled out in block, and someone has now immediately inflated the balloon so that if there's any bleeding going on while we're waiting for that thing to thaw, we're protected. Now the scope is advanced back in. You can see the blocker here sitting in the bronchus intermedius. It's now deployed. We can see that there's really no bleeding, and we had actually already taken a couple biopsies from the lower lobe. Now the blocker is going to be repositioned into the right main stem bronchus. And the right main can be a little bit trickier to block because of the right upper lobe and the propensity for this thing to fling up to the left if you overinflate it. So it's very helpful to block it first, see how much volume you put in. And now we've went ahead and taken a right upper lobe biopsy. I had cut that out. And so the right upper lobe has now been biopsied. We check for any distal soilage of blood, clean things up. That looks good. And again, check the right upper lobe, make sure that there's no significant bleeding. And that's usually what things are going to look like. And so that looks pretty good there. Now, we don't do it anymore, but I think at the very beginning, there was a couple done with the rigid bronchoscope. And that's nice because you've got a big lumen, but I think it's mostly unnecessary. An advantage is that you can also use different kinds of balloons, Fogarty balloons, other balloons where you can maybe put more distally. So there are some potential advantages. The rest of the procedure is exactly the same. Other thing I don't like is you're not going to have the seal of the cuff. We can go to the next video. And so this next video shows what happens when you get down and you actually have a bleed. And so this patient, we got down, deflated the balloon, and you can see immediately there's some bleeding, and that's just really only a second or two of blood. And that could have been 10 or 20 seconds of that soiling the left lung, but instead we had a blocker. This is how we did it a couple years ago. There's a couple things I'd like to highlight. We actually overinflated the balloon here, so we unnecessarily just blocked the right upper lobe. Ideally, the blocker would have been a little bit further down, and you have to be careful about that. But it's still doing its job. Now it's being deflated a little bit so that we don't at least block the right upper lobe. And once you've got a handle on things, you can deflate it and maybe wedge or get cold saline or even wait it out. But the point is, this blocker made what could have been a really catastrophic bleed to really not that big deal at all. That bleeding stopped and the patient did just fine. So, by now maybe these blockers seem like a good thing, but they aren't perfect. They can create their own problems. I've seen cases where the size 8 endotracheal tube, which has an outer diameter of 11 millimeters, plus the diameter of the blocker is just too big to fit in the airway. You want to be careful it doesn't deploy too deep. Like I mentioned, it's a very stiff, and they can very easily migrate. And so if you've got this thing sitting in the right mainstem bronchus and someone adjusts their head, even minimally, these things can pop out and cause a whole new problem. Fluoroscopy can be really handy. Hypoxia can happen if you're going to isolate a whole lung. And so if a patient's borderline at all, I think it's helpful to inflate the balloon just to make sure that you don't cause hypoxia in the event that you have to use it. And so someone asked me if you can use a Fogarty balloon with a flexible scope. You can. The problem is the Fogarty balloon doesn't have an easy way to put external to the tube, and if you put it internal inside the tube, you don't have room for the scope. If you put it in the bronchoscope itself, you can't do that until you put the scope back down. And so there are ways to use a Fogarty balloon, and we have used it before, a really small Fogarty balloon with a big ET tube. There are ways to make it work, and I can talk about a couple of those. In fact, that happened to be the next slide. So the Fogarty balloon in the ET tube next to the bronchoscope, it has to be a pretty small Fogarty, and these end up being kind of flimsy. And so when you pull the whole scope back with the cryoprobe, it can bend and dislodge. I think the Fogarty really pairs best with the rigid bronchoscope, and the nice part about that is you could maybe park it right in the lateral segment or anterior segment because it's a much more pliable tube. So I don't think that, or balloon. So I don't think that that's a bad thing to do in the right setting. There are endotracheal tubes with external working channels out there that are available in some countries. So a couple other just things that I've noted about this cryoprobe. It's a wire, and the wire has a lot of memory to it. And so down into the right, the lower lobe, it'll often come out fairly straight, and you can reliably know where you're at in the airway. But in the upper lobe, it's going to have a bend to it. And so if you're thinking that you can use radial probe to really know where the blood vessels are, you might be just a bit off. And so I don't think I'd overly count on that. In fact, someone just asked me about using the radial probe. So here's the next slide. So this is what happens if you put a little bit of bend in your cryoprobe and you put the cryoprobe out without it being in the airway. You can see it makes a U. And here's just another view of that in the right upper lobe. And so it's not that I would say the radial probe is a terrible idea, but it's something that I would not hang my hat on. I mean, even just a little bit of a bend might put you out into a different angle than the radial probe. I can't prove that it's not good, but I would be very skeptical, as you can see here from that fluoro image. In fact, if I get a bend like this, couple things. One, I might try to reposition it so that it comes out a little bit more straight. I'd also be a little bit worried that when I pull back a centimeter, that I'm really just straightening the wire. So just be real careful about knowing where your probe is at. And so, we talked about bleeding. The other immediate complication you should be really familiar with treating is a pneumothorax. Someone has a question. What is the complication rate bleeding in pneumothorax at your facility using the method we showed in the video? We had a real hard time with pneumothorax was easy. In the 74 patient study we had, we in fact only had one pneumothorax, but I do think we probably got a little bit lucky. But we had 1 out of 74 in that series, but we've had some since, so I'm guessing we're probably sitting around 5% if I had to guess. The rate of bleeding really depends on how you define it. if you have a controlled bleed with a blocker, do you call that a big bleed, or do you say that was just a controlled bleed? So I think how we define it is tricky. I mean, we called in our study that went up through September 2015 that we had I think a 22% moderate bleeding rate, but it was very hard looking through the CT scan to actually know what our true bleeding rate is. I'm going to hold a couple questions so I can get through the end of here. Assessing for pneumothorax I think is critical. From a patient standpoint, if they're going to have a pneumothorax, they'd rather wake up with a chest tube in than to be met in recovery and tell them they have to go have another procedure done and more pain and more sedation or just more anxiety. And so if you can find out they have a pneumothorax before they leave the room, I think it's critical. So we use fluoro sort of to give us an idea if there's a big pneumothorax. And here's a patient where we can see a large pneumothorax. I just lost the slides, Russ. There we go again. And now we're going to go ahead and go to a video of pigtail catheter placement under fluoro. And so this is the same patient I was just showing you. This happened to be a patient with a very advanced BMI, so there's a pretty long needle here to get to the soft tissue. But what you want to do is find a good safe spot, either anteriorly or maybe slightly laterally, go over the rib. You can advance the guide wire in. And what's nice about this is you don't have to reposition the patient at all. They're already supine, and this will work just fine for a pigtail under fluoro. And so now the guide wire or the dilator is being advanced, and you can see where the end of the patient's soft tissue is here. So this was one that fluoro was certainly helpful to have. And so now the patient has been dilated. The pigtails being advanced in. Now these pigtails have a pretty sharp stiffener, so you want to really just get into the pleural space and then slide the pigtail in over the stiffener. And this happens to be a locking loop pigtail, but you can use this same method using various chest drainage systems. But the pigtail will be pulled tight here in a second. Now the patient's going to be hooked up to suction, and if you watch this pneumothorax, you can see just how quickly they'll resolve. And so the patient can leave with a pigtail catheter in place rather than have to find out in recovery that they have to come back for another procedure. It also can be a bit challenging when you have a pneumothorax in recovery. These are patients who already have interstitial lung disease, and there might already be another patient in your procedure room, and so that can add a little bit of chaos to your morning, that's for sure. And so, due to time, I'm going to go pretty fast over these last few slides here. So we talked about immediate complications. We've seen delayed pneumothoraces. We've had a case of a lung abscess, and acute exacerbations of ILD have been reported. Here's just a lung abscess that we had a few weeks out from cryobiopsy. I think the acute exacerbations of ILD is something really critical that these registries start to report. I don't think we really know the true incidence of this yet. I think we're all confident that it's less than surgical lung biopsy, but this is another important area. So, in summary, I think the ideal cryobiopsy technique is not settled, but you do want to be able to quickly manage bleeding and pneumothorax, and patients do need to know of the risks, and the late complications are rare, but they can happen. So I'll turn it over to any questions.
Great talk, Ryan. There's a couple questions at the bottom. The Fogarty question you answered, the radial probe, and we have a question from Colleen Keys about how you approach the target. Is it based on CT or just random areas?
It's based on CT, and Fabien can certainly comment on this too. I mean, I think areas that look active, if you're thinking HP and you've got other areas of ground glass and things like that, you might go for some of that too. If it's a predominantly upper lobe disease, maybe you'll work harder there than you will in the lower lobe. With that said, I don't like to do biopsies that are completely out of plane with fluoroscopy. So the anterior and lateral segments of the right lower lobe are good. Maybe the more posterior branch off the anterior segment of the right upper lobe can be a good spot too. But maintaining a safe biopsy is the trump card, but we do, of course, want to go for where the CT steers us.
Yeah, I'll just add, I just saw a question that just popped up about yielded peribronchovascular disease. I think for peribronchovascular disease, you probably don't need cryobiopsy. I think you need cryobiopsy when you suspect IPF. And when you suspect IPF, you want to be close to the secondary lobule. So you want to be close to the pleura at risk of getting more pneumos. But again, with the trade-off that you're going to get probably going to get less bleeding. With regards to Colleen's questions, I asked the same question to Anna Louise Katzenstein and Jeff Myers from Michigan and Tom Colby and a variety of others, as well as radiologists, and they all had different answers. So probably the best recommendation is that you want to avoid being too proximal, you want to avoid being in a completely normal area, and you want to avoid being in honeycomb or burned out fibrosis. Beyond that, I don't think we know where it's the best, where the best location is, and B, because of the problem that Ryan mentioned, that it's really actually hard to control where that cryoprobe is going to go. You can't really, precisely determine where that probe tip will end up. We have a well-written protocol for navigation cryobiopsy, but honestly, I'm not sure this is ever going to pan out with the probes that we have now.
Quick point, the recording is going to end in a second. However, as long as our speakers are able to answer questions, we'll be able to continue. I hate to jump in with a question, but I just had to get it off my chest. When you have a hospital that does not have a expert lung pathologist, do you have any opinions on external review with the thought of you're going to lose the multidisciplinary approach in those institutions, and whether that should be done?
Well, so the multidisciplinary approach can include a reviewed path from an expert at a different institution, and this actually happens quite a bit. So probably the pathologist that has the most experience in reviewing cryobiopsy slides is Tom Colby, and he's at Mayo in Scottsdale, Arizona, and he's reviewing hundreds of them and gets them from people that don't have, readily available expert pathologists. So I think it's definitely feasible, and if one of you guys is going to start doing this and don't feel there's clearly a learning curve for pathologists to start feeling confident calling UIP on a smaller biopsy than a surgical lung biopsy, but it's definitely doable.
I see another question about literature for big bleed and pneumo in the same patient, and I don't know of that. The idea of it terrifies me. I mean, I think it's possible, but usually if you're in pneumo territory, you're a little bit further away from the big blood vessels, but I certainly think that it's possible. Let's see, there's a lot of questions coming through. Fabien, do you have any, let's see, where are we at?
So additional questions that we have is, go ahead, Russ.
We have a few questions that sort of are similar to some previous ones, so I'd like to skip over, if it's okay, to Dr. Chada's question regarding observation after a bleed and whether you would discharge a patient home same day. The exact question is, if you use a blocker due to a bleed, would you discharge a patient after a few hours, or would you observe them overnight?
It really depends how your patient is looking, right? So somebody who comes in with good functional reserve that has a bleed that will take out 2 lobes is potentially a patient that can go home. And so conversely, somebody who has very limited lung reserve and get a severe bleed in the right lower lobe, that may be enough for the patient to be intubated in the ICU for a couple of days. So, that's where patient selection is crucial. And you want to avoid patients that are not likely to tolerate a haircut, and then of course you want to make sure that you inflate. I think Ryan mentioned this during his talk, but when you place that prophylactic bronchial blocker, you should inflate it and wait a good 3-4 minutes to see if the patient desaturates to a level that is not manageable. Because if that's the case and you have a bleed and that's your sole option to control the bleed, then you're going to find yourself in trouble.
Yeah, absolutely. I think always inflating first is pretty critical, especially if you're at all worried. They come in on a liter or two, or they just don't eyeball well.
About the question on multiple segments and multiple lobes. So multiple segments is something that has been looked at recently by the Poleti group. Again, they publish pretty much everything that gets published in cryobiopsies, and they have a markedly improved diagnostic yield biopsying multiple segments of the same lobe. What nobody's looked at yet is for cryobiopsies, whether biopsying different lobes will make a difference. But we already know the answer to that question because we know there's 20 to 25% of patients with IPF that have interlobar heterogeneity. In other words, they have UIP in one lobe and NSIP in the other. And when this happens, the UIP trumps everything. So we really should biopsy different lobes. Again, we try to biopsy the lower lobe and then maybe the lateral segment of the right middle lobe. If you start biopsying the right upper lobe, which sometimes we have to, but that means potentially you would have to occlude an entire lung, which in these patients is not often well tolerated.
Yeah, I agree. And like we were saying, it's a much harder lobe to block just because if you overinflate the balloon, it can fling to the left main stem bronchus. If you underinflate the balloon, it's not going to adequately block the right upper lobe, and then there's a hypoxia. But yeah, we if it looks like maybe HP is in the leading differential, maybe that's a good one to do that on. But
That's something that we've seen happen a couple of times is that you get a perfectly positioned balloon and you get your cryobiopsy from the lateral segment of the right lower lobe, and then you get a big bleed and it's coming from from the superior segment.
Yeah.
And so you get just same way you get collateral ventilation, you can get collateral bleeding. Thankfully, it's not nearly as bad as a big bleed without a blocker at all, but that can happen and sometimes a little bit tricky.
There's another question I see here about the two-scope technique with the balloon. I guess I don't know the answer. The question was using moderate sedation, and let's see, I'm losing the view here again. Russ, can you repeat that question about?
Dr. Lesneau was just describing a method that's interesting that they use where they use two bronchoscopes, one with cryo, and second with a balloon occlusion catheter within it, and have been successful with relatively few complications. They want to know, just would like to know your thoughts on that technique.
I guess right now there's another big study that did that, the 106 patients, and they did it a little bit differently, but the same idea. I guess my biggest concern would be what happens when you hit that truly massive bleed patient. And so, what if you take the one biopsy that the patient has a big cough, moves his head, and suddenly you have a hard time getting that second scope? And now these sound like they're experts and very swift bronchoscopists, and so. Maybe you can get away with it, but if you did have a big bleed and you're taking out a whole lung now for a prolonged period of time, I'd worry about oxygenation. And then if you've got your bronchoscope in there with a balloon occluding it, it would be difficult to get the ET tube in without removing the scope, and hence the balloon. But maybe Fabien has other ideas, or maybe you've thought of workarounds to that, but that would be my initial thought.
Yeah, I agree. I mean, we talked about this when we started writing this guideline, decided that, it's just so convenient and so safe to have a broncho blocker. It just doesn't make sense to me to get a chance of, you showed in your video, Ryan, you get a massive bleed, it takes seconds. So, even if you're coming back in with another scope and, you still have a potential catastrophe there. So in order to avoid all this, having a blocker that you inflate as soon as the biopsy is taken, I think that's, in the absence of more definitive data, the safest way to do it, in my opinion.
And I think we need to hold ourselves to standards similar to maybe, for central line. How many people you need to full body drape or do various things to prevent a complication? And we do everything we possibly can in the ICU for those sorts of things, and maybe we should be using the same, hold ourselves to the same metric for bronchoscopy, or at least as much as feasible.
I think the overall impression from the ILD community is that this is a really promising technique that needs to be standardized and for which we need more data. The worst thing we can do, I think, is doing it so differently across centers that we don't get reliable outcome and complication and yield data, and have this procedure that I think could potentially be paradigm shifting in ILD fade away because we haven't done a good job, as interventional pulmonologists to do it. At least everybody's going to still do it a little bit differently, but we should have kind of general guidelines that we're going to follow, and starting with the safest way to do it is always better, and then we can decide later on whether we can we can tweak it a little bit, but I think we need to be as safe as we can possibly be right now.
I agree 100%.
Dr. Gilday.
For the sake of the hour, I'm going to just interject that we have one comment from a very experienced physician amongst us, Tom Gilday, who is mentioning that they're working on coming up with new CPT codes for cryobiopsy, so everyone is encouraged to get involved with the RUC process. And then the second and last question that I wanted to field for our panel of experts for the night is, are there any subgroups of ILD that you would suggest going to a surgical lung biopsy for?
Ryan, you want to take this one first? Or?
Well, I guess I don't. I guess I don't know what subgroups would be good. I can tell you ones that I thought we would get that we haven't. The ILD associated with CVID. I'm blanking on the word. Fabien, help me out. What's the
with CVID? That'd be granulomatous interstitial lung disease.
Yeah, the granulomatous ILD. We've gotten it. It seems like that should be just fantastic for a cryoprobe. I'm not sure why we've had a little bit of trouble getting that one, but for people for CVID and they really want to know what that is, we've had a couple that it just hasn't given quite enough for them to call it. But there's definitely case reports where that's worked just fine. I don't know of any other specific subsets that we really have to start with anything but a cryobiopsy.
I think
I worry about patients who have a lot of traction bronchiectasis in doing a cryobiopsy, or really any biopsy. But you can measure some of these patients' airways, and they're 2 or 3 millimeters all the way out to the pleura. I mean, those patients I'm really extremely reluctant to put a cryoprobe down in. And then, of course, patients with pulmonary hypertension, I think, is maybe the biggest category.
So I think the time is running out, but if the speakers are okay, any additional questions, we'd be happy to relay to you an email and have and specifically respond to those people with questions. Is that okay for us to do?
Sure.
Yeah.
Great. I think we'll probably end the recording, and end the webinar here in a second. I want to thank you guys for an incredible talk. It was our best attended so far. Obviously, this is an issue that is at the forefront of everybody's minds, and I think it is going to be, it is obviously a huge step in our management or diagnosis of patients with ILD. Thank you.
Thank you.
Thanks.